Okay, welcome to the Pechakucha event on October 7th. Today we are joined by Dr. Phillip Schnarrs and Dr. Lynn, who will be talking about their sexual and gender minority research. Many of you will be watching this retroactively, so be sure to reach out if you have any questions. And we'll go ahead and get started. Dr. Schnarrs, if you would like to lead us off today.
Sure. Thank you for the introduction, Yana, and thank you for the opportunity to present this work here today. I'm going to be talking a little bit about the COVID-19 and You project. I also want to acknowledge my collaborators, Oralia Loza, Erica Sizak, Brett Cooper, and Eliza Norwood, as well as the Texas COVID-19 Coalition. Just to give you a little bit more background about the Texas COVID-19 Coalition, this is a group of 30 plus individuals and organizations across the state that represent all of the public health regions in Texas. We also have 4 statewide organizations that were a part of the project, which are the Transgender Education Network of Texas, Trans Forward, which is a PCORI-funded project through Texas Health Institute, Equality Texas, as well as Texas Pride Impact Fund. Just a little bit of background about why we were doing this study. There are persistent health inequities that exist across the United States and specifically in Texas. However, there's really limited data about what these inequities are because we don't really collect sexual orientation or gender identity data at the state level. And because of that, we really didn't understand what was going on with this population or these populations during the COVID-19 pandemic. A little bit of information about COVID-19 and Texas. So as of yesterday, Texas had the second highest number of total cases of COVID-19 in the United States. They had the 4th highest number of deaths in the country. And in the past 7 days, we're number 1 in the number of new cases across the country. So the aims of this study were to describe the experiences of sexual and gender diverse Texans during the COVID-19 pandemic, as well as identify differences across gender identity, race, and ethnicity. So this is a 3-part study. What I'll be presenting on is the first online survey that we conducted. We're about ready to launch an interview study in the coming weeks that will pull respondents from the online survey to understand their experiences a little bit more in depth. And then we plan to do a follow-up survey later this year with the same survey respondents to see how things are changing for them over time. In order to recruit for the survey, we left the partnerships that we developed through the coalition. The organizations helped us to recruit individuals throughout the state. We leveraged social media. We had additional participant pools from previous studies that we contacted. And we also did some respondent-driven samplings for those harder to reach populations, specifically BIPOC, trans and gender diverse individuals that we worked really closely with grassroots organizations across the state. The survey itself covered a variety of things from COVID-19 outcomes, vaccine willingness, mental health, preventative behaviors related to 19 issues related to mental health and isolation, substance use, sexual behavior, and violence. Overall, the data that I'm reporting on today is from 1,348 respondents who completed all of the survey items. You may see that the sample size changes throughout this presentation because individuals were able to respond no preference or no response or not applicable, but we did want to keep those folks included in the overall presentation of results. Overall, 42% of the sample was Latinx of any race or were persons of color, and 22% of the sample was transgender or gender diverse identified. So the first thing that I'm going to cover right now are just some testing, areas of testing around COVID-19, rates of COVID-19 across the state, as well as vaccine willingness, and I'll break this down by gender identity as well as race and ethnicity. So for the total sample, we saw that about 13% of the sample had been tested for COVID-19, and we saw no significant differences between cisgender and transgender or gender diverse individuals in terms of testing for COVID-19. However, we did note that there were differences in terms of race and ethnicity, with individuals who identified as Latinx and as people of color were more likely to have tested compared to white non-Latinx folks. In terms of the positivity rate, overall, 15% of the sample indicated they had been told by a healthcare provider that they had tested positive for COVID-19. Again, we saw no differences in terms of gender identity, although transgender and gender diverse individuals did have a higher positivity rate. And we also noted that in terms of positivity rate, individuals who identified as a person of color and Latinx had higher positivity rate compared to individuals who were white and not Latinx. We also asked several questions about willingness to get a vaccine, and what we saw overall was about 90% of the sample, 91% of the sample reported that they were at least somewhat willing to get a vaccine when it was available. And we didn't see, again, differences in terms of gender identity with willingness to get a COVID-19 vaccine. We did, however, see differences in terms of whether or not an individual identified as a person of color compared to white non-Latinx. We saw that individuals who were people of color and Latinx and people of color who were not Latinx were significantly less likely to report willingness to get a vaccine when it was available. The next set of questions are going to talk about shelter in place and specifically violence in the home during shelter in place. So what we really wanted to understand at first was, were individuals having to shelter in place with someone who didn't accept them from being LGBTQ? And what we saw overall was that 5% of the sample reported this. And we did see a significant difference between cisgender and transgender individuals, with only 4% of cisgender individuals reporting this, but 11% of transgender and gender diverse people reporting this on the survey. Then we also wanted to understand violence in the home, and what we saw was that transgender individuals across 3 different types of people, so relationship partner, family member, and someone I live with, they more frequently reported violence compared to cisgender individuals, but we saw significant differences in terms of violence experienced from a family member or someone else they lived with when comparing transgender to cisgender individuals. And then in terms of race and ethnicity, we saw that individuals who identified as people of color were more likely to report that they had to shelter in place with someone who didn't accept them for being LGBTQ compared to white non-Latinx LGBTQ individuals. And while there was no difference across race and ethnicity in terms of violence experienced from a relationship partner in the home, we did note that there was significant differences in terms of violence experienced by family members across race and ethnicity compared to white non-Latinx individuals. And that we also saw that the individuals experience violence in the home from someone else if they identified as a person of color. The last set of variables that I'm going to talk about are related to mental health during the COVID-19 pandemic. So we saw that overall, that more than half of transgender and gender diverse individuals reported that they had moderate to severe depression and anxiety symptoms. And this was measured using the PHQ-4, which measures symptomology of depression and anxiety. We also saw significant differences in terms of whether or not an individual was a person of color, with people of color reporting having higher rates of moderate to severe depression and anxiety compared to white non-Latinx individuals. We also wanted to understand experiences of isolation. And what we found was that overall, about just under 2/3 of the entire sample reported that they felt like they were isolated or alone during the pandemic, with significantly more transgender individuals reporting this compared to cisgender individuals. We did not see any differences in terms of feeling isolated or alone among across race and ethnicity. We did see issues in terms of folks not feeling like they had control over what was happening to them. About 80% of the sample reported this, and we saw that about 90% of transgender and gender diverse individuals reported that they felt like they had no control over what was happening to them during the pandemic, compared to only 77% of cisgender individuals. we did not see these same differences in terms of race and ethnicity, although 22% or 78% of individuals who were white, non-Latinx reported having no feeling like they felt like they had no control over what was happening to them. And we saw that between 80 and 84% of people of color and individuals who identified as Latinx reported that they had no control over what was happening to them, even though there were no significant differences. So some quick summary of the overall findings, some of the things we didn't present here today, but gender and racial ethnic disparities did persist from the start of the pandemic. Other findings that we had were related to unemployment and financial insecurity, that these are things that were occurring prior to the COVID-19 pandemic, that the pandemic just exacerbated and made more prevalent. And we did see differences in terms of gender differences based upon mental health and barriers to healthcare access and services. If you're interested in some of that data, I'm happy to talk with you more about it offline. And we also did note that there were differences in terms of COVID-19 employment, financial security, and housing across racial and ethnic lines. Some quick limitations of this study is there's no statewide data, as I mentioned in the beginning, prior to COVID-19 that includes SOGI data, sexual orientation and gender identity. And so we can't really determine temporal associations, also because this was a cross-sectional survey. We also note that this is an online survey, so it may not have reached those populations who are likely most impacted by the COVID-19 pandemic. Some strengths of the study is that Texas has historically not addressed LGBTQ rights or needs in understanding what the needs are of this community. And this study is the first to look at LGBTQ health at a statewide level. We also want to acknowledge that the efforts to do this were really brought together, came together because of our ability to build a coalition of individuals across the state, and that we plan to continue this collaboration to continue to collect statewide data on the health and well-being of sexual and gender diverse Texans. Next, what we're going to be doing is we are in the process of providing reports to the community and working on our executive summary that will go out, and that executive summary will support programmatic grants to support LGBTQ communities across the state during the COVID-19 pandemic. We're also going to begin to look at the intersection of race and ethnicity with gender identity and statistical models. And as I said earlier, we are launching a qualitative study here in the next couple weeks, and we will also be launching the survey in Spanish to understand the needs of that community as well. And that's all that I have. Thank you.
Thank you so much, Dr. Schnarrs. If anyone has any questions, then now is the time. Otherwise, we can pass the mic over to Dr. Rue, who will talk about puberty blockers and how parents and adolescents decide on hormone therapy. And I'm gonna unmute you. Dr. Rue, you may have to unmute on your end.
Can I go back to the, I just realized that I left something out of this presentation. So can I stop sharing the screen for a minute?
Oh yeah, you're not sharing right now.
Oh, I'm okay. Well, but I have it up on the full. What do I need to escape here? Never mind. I figured it out. Just give me 1 minute here, because I realized you could have me share the screen if you want.
Okay, you should have the option if you see the option to share screen.
Okay, wait a second. I think the problem is that I made my my view of it fill the whole screen. So when it does that, I don't have any other options. Okay, hi out there. Thank you all for being patient here while I get this set up. Okay. Does that look right now? Does it, you've got the first slide, right? All right. Thank you for inviting me to share this. I need to let you know that this is all very much works in progress. In fact, one of the articles that I'm going to be talking about in this short presentation is one that I got another review back today from the same place that we've been trying to get this review published. And this is now asking me for the third revision. Would you please remove this phrase from this section and put it in this section? It's been unreal, but nevertheless, so I do want to acknowledge my two co-investigators. Some of you may know Maria Monge from the Dell Medical School. She's a pediatrician, assistant professor, and then Kara Young from our School of Nursing just got promoted to it. This is her first year being an associate professor, and she's a women's health practitioner. So as most of you probably know, the number of children who have gender dysphoria is increasing. And gender dysphoria refers to an anxiety and discomfort from feeling that one's sex is not the same as that which is shown on the birth certificate. We sometimes also refer to people like this as gender variant children. And gender variant children with gender dysphoria are at higher risk for both depression and attempted suicide than cisgender children. And children with gender dysphoria also have a lower quality of life. We have guidelines now from two professional societies that the use of gonadotropin-releasing hormone agonists may be the best way to deal with unfolding puberty in these children. And the two groups are the World Professional Association for Transgender Health, or WPATH, and the Endocrine Society of the US. Both of these want to affirm that care for transgender and gender diverse children and adolescents should be the standard of care. So gonadotropin-releasing hormone agonists, or GnRHA, inhibit puberty development, and they usually begin to give these hormones in the very early Tanner stages, stage 2 for females and no more than stage 3 in males. At this point in time, they are believed to be fully reversible, and the great advantage of them is that they give both the child and his or her parents time to really decide the consequences of changing and more time to actually experiment with the social reality of being the other sex. So far, we know that the positive outcomes of using puberty blockers are we get improved affect, we have improved psychological functioning, in particular decreased depression, and over time we've seen a decrease in suicidal ideation and attempts. There are, however, some adverse outcomes of using puberty blockers, and these are the ones we know about right now. This is an area that is still just wide open to exploration. It does tend to slow one's growth pattern. It can reduce in decreased height velocity. It can also reduce or result in decreased bone turnover. And the cost of these drugs is relatively high, and most insurance companies won't cover it. So as parents in one study said, am I doing the right thing if I allow my child to be given these hormones? So parents' approaches in this particular study by Gray and colleagues were that their approaches to gender variant children were to try to rescue them from their experiences of stigma and hurt by society, and or to advocate for a more tolerant world. So the current literature is limited by a lack of first-person experiences of gender variant youth. We have not heard their voices. It also lacks rigorous longitudinal studies of youth who are taking puberty blockers. The access to puberty blockers is not universal. And most studies to date have included the majority of white Caucasian samples. So Dr. Monge and Dr. Young and I set out to do a qualitative descriptive study, the purpose of which was to describe how parents and their prepubescent children make the decision to use puberty blocking hormones. The sample to date, now we've been trying to collect data for close to a year now, and so far, just from Dr. Monge's clinic here in Austin, we have been able to recruit 6 children, and their ages so far have been from 9 to 13, and 8 of their parents. Our study has had IRB approval with written parental permission and child assent. So in general, we have not gotten enough data back yet to be really analyzing this, but so far, just from what I've heard and what little I've read over and over again from their transcripts, is that their decision to use this form of puberty blocking was generally easy for these reasons, because it gives hope to our child, and it's the best thing we can do to avoid a later suicide. Those kinds of reasons are given over and over again. What has made it more difficult is that they don't know the long-range consequences. The other thing that has made it difficult is that they need to be allowed time to grieve for their lost child. And it's not really that they've lost the child, but any of you who are parents know that once a child is born, our society puts so much emphasis on, is this a boy? Is this a girl? And all of a sudden, the parents and the whole society starts making expectations about how that child's life is going to unfold and what they're going to be like as an adult. And so parents and others around them need to grieve about the child that is lost. The things that have helped parents to make their decisions include having an honest and direct discussion with their pediatrician and being then referred to a specialist like Dr. Monge, who knows how to actually give these drugs and to follow them along and knows what to look for. It's also been helpful for them to read lay literature about gender variant children. And it's also been helpful to have a support group of parents, whether they get to know these people in real time or just refer to them online. Some of the parents' verbatim responses have been saying to their child, you're the one that will have to go through this, so I'm supporting you in whatever decision you want. I'm not going to tell you what to do, nor not to, or what not to do. Or another one would say, I just want him to be happy. That's what matters to me. I'll support him if that's what he chooses. In all the cases that we have interviewed so far, nobody has been not supportive of their children. So to date, we have a very biased sample, if you will. And the children's responses have been, okay, we asked a question, what do you think these hormones do to you? And this one person said, well, it would stop my whatever that word is, pubertal hormones to give me more time to make a decision about who I would choose to be. Another one said, it will stop my voice from changing. And another one said, I won't have to get a period. I asked them, what was the worst thing about taking these medications? And the first one that I quoted on the previous slide, it was a 12-year-old assigned male at birth who said, I'm not a big fan of shots. And then the other way that I would get it with an implant, well, that would be very expensive. And a 13-year-old who was assigned female at birth said, well, it might affect your growth in general. I'm probably not going to be tall anyways. And another who was assigned male at birth, well, it's also expensive for them, talking about her parents, it's also expensive for them to administer the drugs to me. That particular child was really sensitive about what it was costing the parents to pay for this drug. So these are just a few of the current comments that we have from children and their parents. We're hoping to recruit at least a few more cases, and then we need to be able to figure out, where are we going to find the contrary cases? Where do we access the adolescent and parent who have said, nope, I just can't do this. I don't want to take these drugs, or the parent who says, nope, you're not going to take those drugs. I mean, this is why we know so little, I think, about children of this age and their feelings of gender invariance, because it's very hard to access families and children where there's a discordant connection between what the child wants and what the parent is willing to allow in that household. A lot of my work with homeless adolescents has taught me that many children run away from home because they're not accepted in their homes for who they really are. So our future directions also, we know at this time, are going to advocate for gender affirming care, not only for children and not only for adults, but also for children, because we're getting to see more and more of this coming to our attention. And we also want to be able to advocate for interdisciplinary teams that are trained to provide gender affirming care. And we really want to advocate for conducting rigorous longitudinal and mixed methods studies. And that's all there is to date. So, did I finish in my short amount of time?
Oh, you did wonderful. Thank you so much, Dr. Rue.
Sure.
If anyone has any questions, then now is a good time. Otherwise, thank you to both of our presenters. Y'all are doing some wonderful work, and we'd love to keep up to date with how both of these projects progress through the pop-up website and listserv. So thank you so much for presenting. I'll open the floor up to questions.
Lynn, I thank you so much for presenting these early findings. I think this is a really interesting study, and
Thank you.
Point about we can't really fully understand the experiences because there's parents who just won't let their children, their kids be involved, I think is right to the point. And I also wonder too, have you worked with or have connection to Trans Forward at all? Because this is something
I don't even know about them.
Yeah, it's a PCORI funded project that's statewide. I'm happy to make that connection. It's because they're really focused. They're about patient-centered stuff, but their primary focus is really on mental health and suicidality. And I think what you're doing fits so well into what they're trying to accomplish that I want to make sure that y'all get connected.
I would love that. Thank you very much. And you know how to get a hold of me, I think. So.
Yeah, I have your email for sure. I'll reach out this afternoon.
Okay.
Thanks, Lynn.
Thank you. Any other questions or comments? Well, thank you for this opportunity to make this presentation.
Of course, thank all of you for joining, and we hope to see y'all again for some further events.